Please welcome moderator, Dr. Veeravagu.
All right, good evening, everybody. It's nice to see everyone, and I realize our debate stands between you and probably your bottle of tequila, so we're going to get this going. I am very excited to introduce this debate between Jim and John. We're going to be talking about early versus late intervention for spinal cord injury. So I'll start off by presenting a case and then maybe ask the audience what you think and what your timeline for surgery will be, and then let's see how things go with the science that's presented. Our participants, Jim Harrop and John Hurlbert, we have two very distinguished faculty members in this space. So here's a 78-year-old male who presents after a fall at home with chin impact and neck hyperextension. The patient has severe burning in the hands, the inability to utilize the upper extremities for useful movement. They're in the emergency department, their pain is severe, lower extremity paresthesias as well. Hand grip is weak, lower extremities are weak as well. You can see their exam here with significant impact to the utilization of their hand grip. They have numbness with burning dysesthesias throughout their upper extremity, loss of tone, and a very high PVR. Here are the images: cervical stenosis with severe spinal cord compression, evidence of myelomalacia or T2 cord signal change. You can see the areas of spinal cord injury and spinal cord central stenosis and T2 signal change on the MRI scan. Here's a CT scan. Patient probably has some version of DISH with skeletal hyperostosis throughout. You can see the lower cervical spine, the upper thoracic spine has entered a fusion state. And so the question is, what would you do? So how many people here would consider intervening with a surgery within, let's say, 24 hours? And how many people would let the patient maybe recover in the ICU and plan on the surgery delayed, 24 to 72 hours? Okay, there you have it.
Thank you very much. There's a couple of problems with this debate, just to start off, not to make fun of my moderator. But first of all, the word early was never defined. And two is, I'm not really sure a central cord disease exists, but we'll get into that. And just my psychiatrist put me on mood stabilizers, so I'm going to try to be a little bit calmer than normal. My disclosures aren't really there. So just really for an overview, and I think I need 2 slides to win this debate, but John's a nice guy, so we'll try to hold out. So early surgery, I'm going to define as 24 to 36 hours, and I'll explain that 1 minute. And 2, we seem to believe a myth that a central cord injury is a different animal. And it's gone through decades and centuries of, oh, it's a different problem, it's grandpa fell, he doesn't have a fracture. It's the only spinal cord injury we talk about with a clinical diagnosis based on patient's exam and how they got injured. It's stupid, and it's time to move on, and we'll get into that. And by the way, I'm going to make fun of your slide, too. I'm not really sure Ananon went to med school, but that's all right. We'll go through that. So early surgery, it's obvious. Animal data absolutely proves it. The literature is flawed because there's a ceiling effect, and that's why we haven't been able to show it as well in the central cord injured patients. But if you really want to help your patient, and we don't talk about this anymore, best neurologic recovery, least complications, decreased length of stay, and best recovery. So let's go through it. First, Badawalla's paper, great paper. Everyone missed this part of the paper. Huge registry, over 1,000 patients. They look at early and late surgery. And what they show, early surgery does better. And this was taken over multiple decades. But the thing that most people missed about this is they used the modeling to watch variables. And what they showed is that the drop off the effect happens about 24 to 36 hours. So all the papers done by our predecessors from 36 hours on, you really can't test the whole hypothesis, early surgery or not. And we'll get back to that. So the central cord injury, I got to start talking faster. Netter's diagrams, this is what we believe. The middle of the cord gets injured, stupid. Why do I say that? We all got taught this as ascending, descending. You should probably go back to your medical school and ask for your money back. Why? Because of this. Bunge and many other neuroanatomists have clearly shown that the tracks in humans do not follow what you guys got taught in medical school. This is Bunge's autopsy studies, 3 different papers. I'll zoom it up for John, who's a little aged and can't see that well. Those little dots are all the injured nerves. And I'm not sure, but that sure as hell does not look like a central cord type of injury. It's a mild spinal cord injury that predisposed to the more sensitive neurons, which in humans is what? Everyone except for Praveen, is your hands are your most needed neurons. And this has been shown by other people. This great paper in Journal of Neurosurgery, if you want to look at it, looked at monkeys in different tracks and did a huge analysis of it. All right, so let's go to this case. Falling behind. 78 isn't old, people. 78 is the mean life expectancy. But what most people don't know is you have another 15 years. So don't be saying that 78-year-old is an old person because they have, on average, another 15 years to live. 2, neuropathic pain. It's caused by the DRG getting injured. A rehab doctor told me this a million years ago, said, operate on him early. And I'm like, why? And he goes, their pain gets better. This patient has horrible neuropathic pain. The second thing is, this guy's not a spinal cord injury with a 99 motor score. His motor score is 60, and he's an ASIA C. We'll get into that. Imaging. I blew this up. Why? Because this guy doesn't have a fracture, but if you look really closely, there's an acute component to that disc herniation. And again, here's the CAT scan. Another view, you can see the component of soft tissue there. So there's 3 options. If the patient's obviously getting worse, immediately operative. Patient's getting better, we sit on them. If they're the same, maximize their recovery. This is the animal data. I'm not going to really torture you on it. 35% better neurologic outcome if you treat them early. Large series. Our guidelines are kind of ridiculous based on old data. Here's the old data, which isn't really helpful. Jim Guest's data, which is probably one of the best older papers. And what did it say? Really small series, 6 patients. But what it clearly showed, and we forget this, shorter hospitalization, less ICU stay with the central cord injuries. Now, this is the big point. If you look at the series, the reason the A's and B's get better is because they have so much more ability to get better. If you go to the C's and the D's, there's less room to recovery, so you need more patients when you're doing this study. That's why our central cord patients, we haven't shown it as well. Looking at the large meta-analysis, clearly with the complete injuries, they do better. The incompletes, we haven't shown as well. Staskis clearly points this out. I'm going to get back to this in a second. We'll go through this. Early surgery, acute surgery, again, this is where we're seeing less than 8 hours. You now start seeing that the complete patients do well, but even the incomplete or the ASIA Cs do well. I'm going to skip through this. This goes back to some of the data that's specific on central cord injury. Body Wallace patients, where they went through propensity scored, and this is one of the first studies that showed what? Central cord injured patients did better with early surgery. Not in the legs, but in the arms, or if they were more severely injured in the ASIA C. This is the last thing, just hot off the press, just came out. You can see the publisher's proofs on it. Largest meta-analysis included 3 other studies. Since I'm running out of time, I'm not going to go into them. But what did it say? It said if you want improved neurologic recovery, do it early. If you want less DVTs, do it early. If you want less complications, do it early. If you want less hospital stay, do it early. And if you want less morbidity, they're about the same. So with that said, really quickly going to Staskis. This is the late surgery patients, 21 patients, 5 stayed the same, 16 got better. Now I'm going to pull out the ASIA Cs, same group, and we look at it, and what do we see? About the same patients, however, 4 patients converted to ASIA Es in that group if they went earlier. So I asked everyone in the group, do you want to be like John Hurlbert and be in the late group where you're a C-plus student, John, with 76%, or do you want to be an A-plus student? So do it early and get your patients better the quickest. Thank you.
Parents embraced it.
Well, thank you. Thank you, Jim, for that. So I want to thank, first of all, the organizing committee for having me up here and congratulate Eric on a great job for a year as chairperson for this society. It's great to be here. I want to summarize for you. We're looking at a 78-year-old with a ground level fall, and he's got dysesthesias and numbness in his upper and lower extremities. According to the ASIA criteria, his ASIA exam shows 2s and 3s in the upper extremities and 4s in the lower extremities. Now, this is important because there are 3 diagnoses in play here. 3 diagnoses I want you to keep in the back of your mind. The first is spinal cord injury without fracture or dislocation. That is different. You heard Jim say it wasn't, but it is different than spinal cord injury with fracture dislocation. Second thing is, on the spectrum of spinal cord injury, he is a central cord syndrome, which means his hands are affected more than his legs. But finally, this patient is an ASIA D, because as you define ASIA D, which is the majority of muscle groups below the level of injury is 3 out of 5 or more, as you can see by the circles, I don't have a pointer, but as you can see by the circles, the majority of muscle function is above a 3 or above. I want to hit pathophysiology, publications, and perspective to kind of make the points I want to. Have you ever asked yourself why the most benign form of central cord syndrome without fracture dislocation only affects the hands and it spares the legs? Well, if you think of strands of spaghetti, holding it in your hand, and you gradually pinch those strands of spaghetti, the spaghetti moves out to the sides. And if you think of those as axons, then what that means is the leg function in the long tracts of the white matter is preserved. That's what we see clinically. So it has to be something as those axons disperse laterally, and I'm not talking about centimeters, I'm talking probably about less than a millimeter. But as they disperse laterally, something else has to be affected to cause the hands to dysfunction. And that would be most likely structures between the axons, structures that are transversing that plane in the axial plane, not going longitudinally up and down. Those structures are fragile and can be disrupted by shear within. If you think of the transverse section of the cervical spinal cord, what comes to mind is the second-order ascending sensory axons that all have to cross through the middle of the gray matter to get over to the other side of the spinal cord before they ascend in the spinal thalamic tracts. In addition, also at risk are the synaptic junctions between the descending secondary motor axons and the alpha motor neurons that are synapsing in the gray matter. And in addition, if you overlay on that the vasculature of the spinal cord, which in the gray matter is very luxurious and very fragile, now when you buckle the ligamentum flavum against a disc osteophyte and everything goes laterally, you can see why this happens. And what with a minor injury, you're going to get sensory loss first in both hands. With a moderate injury, you're going to start to affect the ventral horn synapses, which is going to give you lower motor neuron motor dysfunction in the hands. And with major injuries, again on the spectrum of spinal cord injury without fracture dislocation, you're going to start to see long tract involvement. So you can have ASIA A patients with spinal cord injury without fracture dislocation. In our patient, this is one of my own patients. What you can see here on the axial, this is a patient with numbness and tingling and weakness in their hands, and you can see how the signal change is restricted exactly to the gray matter, showing what the pathophysiology really is, sparing the white matter tracts. So let's look at publications, and Jim kind of went through a number of hand-picked publications. If you look at the literature, notwithstanding we've got a debate here, you'll understand why the literature is varied and scattered. You can pretty much pull the articles you want to make your own arguments. But what I wanted to highlight with this, for those of you in the audience that do tend to treat these more conservatively, if you look at the bottom publication, 4,000 patients surveyed in 255 centers across the United States. 40% of those patients are treated non-operatively. Not talking about delayed surgery, non-operatively. So if you're feeling alone in your conservative management or more conservative care of central cord syndrome without fracture dislocation, don't, because there's a lot of us out there that do it. Let's look at this paper. This was one that Jim touched on a little bit quickly, but I was scanning the author list, and there's a lot of PhDs there. Badawala, Wilson, Vaccaro, Geisler, Failings. And then there's my esteemed colleague, and I don't know what MSQHS is, so I had to look it up, and I still couldn't find it. The only thing I found was MSHQS, which means Masters of Healthcare Quality and Safety. Jim, did you even proofread the proofs of these before you signed off on it? Or were you so happy to publish with the big dogs that you forgot how to spell your name correctly? Be that as it may, there were 3 databases that were combined, and the authors called them a harmonized data set. Doesn't that just make you feel great? It's a harmonized data set. That just means it's a combined data set. And this is the way you get rid of from 1,692 patients down to 75 in each group. I would point out on the right-hand second row, up top, no surgery, 96 patients. 100 patients were excluded because they didn't have surgery, which are likely the central cord patients that we're talking about, by the way. If you go down a couple of more rows, you'll see that there were 300 with complete baseline data. 207 had late surgery, twice as many as 93 who had early surgery. Well, that certainly won't do. So we have to even that out somehow. Let's do a propensity analysis. Let's dump 100 of the late surgery patients, and now we've got 93 patients in each group. Oh, by the way, we forgot that the outcome measures weren't there in 20 patients in each group, so now we're down to 75. So we've got 75 propensity-matched ASIA C and D central cord syndromes, and here are the results. If you look at the difference in ASIA motor scores, 2 points in the upper extremities, statistically significant but not very interesting, and no statistical significance in the difference in the lower extremities. Well, let's dump that. Oh, by the way, the patient we're talking about today is ASIA D, so say goodbye to the patient. Bye-bye. Now we have ASIA Cs. We have 20 in the early group and 24 in the late group. And here are the p-values. We lost our significance in the upper extremities. The lower extremities are 4 and 9.5, which are statistically significant. But that's how you get from 323 down to 20 patients. Are 20 patients going to change your practice patterns? Wait, we're not done. 85% of NASCUS patients had spinal cord injury with fracture dislocation. 60% in the combined data set were suffering from motor vehicle accidents and sports, likely fracture dislocation. So if we get rid of the fracture dislocations in this group, about 50% of them will disappear, and now we're down to 10 or 12. So not really JAMA surgery material, if you ask me. I want to leave you with the perspective of my own. This is my patient treated 2 years ago, 37-year-old ground level fall, light touch impaired in both hands, allodynia in both hands. Here are his motor scores preoperatively. I operated on him within 48 hours. And I used a laminectomy. I used an ultrasonic bone scalpel to take off the lamina. I took off the lamina, not my fellow, not my resident. Post-op allodynia persists. Look at his motor scores. This is me. This guy would have got better if I left him alone for a few days, weeks to cool off. But I hurt him, which makes me wonder, what is it? You can see how I hurt him. What are we trying to treat? Is it acute cord compression? These people don't have acute cord compression. They have contusion. Is it a compartment syndrome we're trying to treat? Is it a reperfusion syndrome we're trying to avoid? And we don't know those answers. So if you're going to make a choice about early versus late, the mechanism is different between the two. The pathophysiology is different. The canal compromise, acute canal compromise, it's not present. The neurology is different. The ASIA scores that they present with are different. And the natural history is different. So don't be side-blinded by the big dogs. Use your common sense and use your practice patterns to do what you think is best. Thank you.
And there.
All right, everyone. Let's put the voting QR code up. And, Eric told me under no circumstance should you give Jim Harrop an opportunity to respond to the presentation. But he essentially threatened my life up here. So you get about a minute to answer the question.
I just want to say, our 6-minute debate, John, people are going to be late for their dinner reservations because it was like 35 minutes. But anyways, I love John. And I got to tell you, I think you really convinced me with the spaghetti. That really got me over. But then when you showed me the case where the guy had no spinal cord compression, and then you operated on him, I'm like, I'm not sure that was a central cord injury.
Happy to show you those slides again.
How's it looking?
Obviously, my supporters don't have.
There you have it. Great job. Great meeting. See you, everybody.